Welcome to this video on neonatal extubation, part 1 of 2. We will cover the strategy, optimizing the attempt, and the readiness checklist for successful extubation. This session is designed for neonatologists and focuses on applied physiology and ventilator support. By Dr. Salem Keshba, neonatal specialist. Section 1 provides the introduction and rationale, emphasizing why extubation requires active planning from the moment of intubation. Minimizing ventilation duration is key to reducing ventilator-associated lung injury and chronic lung disease. Failed extubation is associated with higher morbidity and mortality. Active planning and using a checklist approach starting at intubation reduces failure. Common reasons for extubation failure include severe apneas, hypoxemia, increased work of breathing, and poor respiratory drive. Chapter points. Weaning and extubation requires active planning starting at the time of intubation. A checklist approach reduces extubation failure. Failed extubation leads to increasing morbidity and mortality. Section 2 focuses on the extubation strategy, presenting 3 key steps to reduce failure, centered on a protocol-based approach. The 3 key steps are: first, planning weaning at the time of intubation; second, using a comprehensive checklist to assess readiness; and third, developing a multidisciplinary pre- and post-extubation plan. This systematic approach enhances preparation and improves outcomes. Stabilize on ventilator, assess with checklist. Complete pre/post-extubation plan. Extubate, monitor bedside parameters, and follow agreed post-extubation plan. Section 3 addresses optimizing an extubation attempt, focusing on crucial clinical, ventilator, and blood gas parameters that must be optimized before extubation. Key bedside clinical parameters include a stable heart rate with no bradycardias, a good spontaneous respiratory drive above the backup rate, stable blood pressure, and SpO2 consistently within the target range. Caffeine improves heart rate stability and reduces apneas, making stability of SpO2 and HR the most readily assessed indicators of readiness. Optimal ventilator parameters include using PCAC or PCPSV modes, stable oxygenation at FiO2 less than or equal to 0.40, and a mean airway pressure, or MAP, consistently at or below 7 to 9 cmH2O. A backup rate set below the spontaneous respiratory rate ensures the baby drives respiration. Blood gas parameters target a pH of at least 7.20 and stable PaCO2, allowing for permissive hypercapnia after day 4. Lactate levels should be below 2.5 mmol, indicating adequate systemic perfusion. Hemoglobin should be over 10 grams per deciliter. The respiratory severity score, or RSS, equals FiO2 multiplied by MAP, with values above 2.5 indicating a high risk of failure. A spontaneous breathing trial is a short trial of extubation readiness assessing respiratory effort. Successful extubation requires consistent respiratory rate above backup, no significant recession, stable SpO2, and no increased work of breathing for at least 3 to 10 minutes. The final decision is always multifactorial. Section 4 introduces the Extubation Readiness Checklist, Table 12.1. This provides a systematic assessment before every extubation attempt. Part A of the checklist focuses on respiratory and lung disease factors. Key elements include optimizing surfactant, checking for improving lung disease trends, confirming open lungs via X-ray, addressing secretions, and ensuring metabolic compensation for hypercapnia. Lung disease stabilization and identifying the post-extubation CPAP level are critical. Part B covers systemic and pharmacological factors. Important questions involve assessing respiratory drive through a spontaneous breathing trial and minimizing sedation. Caffeine must be given 24 hours prior for preterm infants. Also, confirm suitability for CPAP regarding lung and abdominal factors, and ensure systemic stability by addressing infection and off inotropes. Part C addresses personnel, hematology, and thresholds. Key checks include optimizing hemoglobin and addressing excess tissue fluid with diuretics. Ensure parents are aware of the plan and risks. A very experienced nurse and senior doctor must be present. Reintubation thresholds must be agreed, documented, and clearly communicated to the entire team before extubation. Section 5 details pre-extubation optimization, covering caffeine, ventilator weaning strategies, and readiness targets to improve extubation success. Caffeine is dosed at a 20 mg per kilogram loading dose, IV or PO, given 24 hours before planned extubation. Maintenance is 5 to 10 mg per kilogram per day. Target levels are 15 to 35 mg per liter, improving central respiratory drive. Ventilator readiness targets include MAP at or below 7 to 9 cmH2O and FiO2 at or below 0.40. To summarize Part 1, readiness involves planning weaning from intubation, using the three-step strategy and the comprehensive checklist. Key targets are MAP less than 9, FiO2 less than 0.4, and a low RSS. Caffeine loading is essential, and re-intubation thresholds must be agreed upon by the entire team.